Again, Ashok. And today, this is another great topic we're going to discuss about the healthcare supply chain, which is at a crossroads. And there's the changing landscape as well as cost implications that are happening. There's been a lot of changes in the healthcare supply chain in the U.S. And last year, you predicted that GPOs are going to consolidate and change their business models, and we are seeing that now. So, what do you think is contributing to this activity?
Justin, thank you very much for having me back. It's always a pleasure to speak to you. If you remember, we had talked about this very specific issue about a year and a half ago. I think there is a strong realization that the traditional GPO model has lived its course, and that fact is supplemented by the increase in the number of regional, local coalitions and integrated delivery networks that are coming up. Many of these coalitions and IDNs are basically forming their own group purchasing, be that delivered by an integrated model or a hybrid where they still utilize some of the GPO contracts, or they are using a third party like a UPS and a FedEx. So there is a lot of momentum happening in that area, and it all drives back to the fact that the old model is not going to work for the next 10 years. And I think various factors coming together is creating a perfect storm to question that model, and that's also forcing the GPOs to consolidate their business model, look at newer technologies, so on and so forth.
Um, as far as this development is concerned, would you see will we be seeing any the cost of healthcare going down?
I believe so. We at Supplycopia definitely see this as a positive development for all the stakeholders, be that the patients, the care providers, and the suppliers. We've always believed that the power of group purchasing as a concept, it's tremendous. It's a great lever to reduce your costs, make the whole area competitive. But we just weren't huge fans of the way this whole concept was being implemented. So we never were against the concept of group purchasing per se, but in the way that message was being delivered or the model that was being implemented. And we definitely see that because of this new development, the competition will increase, and that's going to make the suppliers not lot more nimble, and it's going to make the care providers a lot more matured in their own dealings and in discussions with their suppliers, as a result of which we believe the overall costs will tend to come down. It may not happen immediately, but in the next 6 to 12 months we should see that sort of benefit coming back to the folks that want to receive the care.
What kind of model do you see emerging from the current developments? And can you also describe where you see the future going?
Obviously, many models will emerge from the current events, Dustin. I don't think anybody can put their finger and say these are the exact models that will come up. But we do think that there are two models that will have a profound influence on the cost of the supply chain. One is the traditional GPOs morphing into more of a technology enabled end-to-end solution providers versus the very fee-based model that they have today. So they go ahead and contract with a bunch of suppliers, then they create various preferred suppliers, and then based upon the blessing that's been given to them by the Congress, they charge 3% to the suppliers, and then there are various other dimensions that's out there. uh, we believe that that model is going to change, and the GPOs are going to morph into more of a technology enabled or an end-to-end solution provider than what they are today. But that I think is going to take a little bit of a time, because this transition from where they are today to where they want to be is going to take some time. And the most important thing I think they would have to, kind of internalize and be able to execute is, what is this new monetization model is going to look like? How are they going to make money from this new model? So there are a fair amount of challenges involved in getting from where they are to where they want to be. And also, I think delivering this message in a very coherent, simplified, a uniform way is going to be a challenge, because this new model is going to question a few of their older hypotheses and beliefs. So that's going to be an interesting one to see how it's going to play. The second model, I think, is the local and the national coalitions taking more daring step towards a self-contracting and a distribution model with or without the GPOs. Our read on the situation is that this transformation will happen in kind of two phases. Phase one will be a hybrid model, and phase two is more leaning towards being entirely independent. At least in the next 3 to 5 years, we see both of these models coexisting, and over a period of time, they might merge to become one, or they might entirely become new models. And especially with the with the potential entry of organizations like Amazon, Alibaba, and others into this mix, an entirely different model could emerge today that we don't know. But all of these new models coming up, increasing competition in the market, ultimately is always better for the folks that are looking to receive the care and the hospitals that are looking to provide this care. And obviously for the suppliers, it's going to be an interesting dynamics now that majority of their sales are directly going to be to the hospitals. So it remains to be seen how that mix is going to work out. But definitely we see this as a positive development, and these models will contribute to the overall reduction in the cost of the healthcare.
And how's this situation going to benefit the common man?
Simply put, more competition means lesser cost of goods, and hopefully the hospitals and the care providers will pass on some of the savings, onto the patients, either in terms of the lower procedure level costs, or they have the ability now to treat more people more cost effectively. And there are a lot of economically disadvantaged people in this country who are on Medicare, or they just don't have any insurance at all. And hospitals have been trying to do all of these great deeds all on their own. Now that they have some wind at their back, so that if the cost savings are delivered, then they can probably do a lot more with what they have, Dustin. And also, as you may be aware, that in the last 2 years, we've had more than 200 hospitals close for a lack of resources. And that's a kind of a bad situation to be in. And hopefully these cost savings will help them to be open and continue to prolong the services. And last but not the least, there is a huge community of global manufacturers that have been supplying to original OEMs here in the US. What we believe is that they will directly start working with the hospitals. And if today a manufacturer sitting in China can deliver a $10 product into an American home, then why can't they do the same thing with hospitals? Thereby, I think hospitals will continue to see improvements in their procurement costs, and that will ultimately benefit the common man.
Are you involved with any health systems that are creating their own coalitions or with integrated delivery networks? And if so, can you talk about the challenges and opportunities that you see?
We are involved with a number of health systems, Dustin, across the country. Some of them are smaller and less complex in size, whereas others are tremendously huge and very complicated in nature, both by their the kind of services they offer, the specialties they offer, as well as providing care both in the acute area as well as the subacute area. Our advice to these health systems is not really be traditional in the way they have been doing things all the time, but to start with the end in mind. What does that mean? Is clearly define why do you want to create an independent delivery network? Are you willing to go through that journey? So if the answer is yes, then the questions to consider are you creating this network to service your own facilities, be that acute care or non-acute care, or do you look at it as a revenue generation model that incorporates new members? If the answer is former, i.e., if the IDN is going to be created only to support their existing facilities, then the solution is somewhat simpler. In that case, we measure their desire and the appetite for risk for creating an integrated model with a self distribution or in partnership with an organization like a UPS, FedEx. You can outsource some of the fulfillment to these organizations. These organizations then would need to plan for a strategic sourcing team, category management experts, contract management experts. So currently all of these are being delivered through the GPO organization. So they might want to keep some of these in-house, but to leverage the GPOs to the extent that they can, thereby creating some kind of a hybrid model where they get best of the both worlds. Now, the more complicated option, but a lot more forward thinking model is when you say, I want to become an integrated delivery network, but I want to be able to look at this model as beyond cost savings. We want to be a revenue generation model. That's when the situation gets a little complicated, but it's something that is the future. What we advise our clients in that sort of a situation is don't fall into the trap of the past, meaning don't get too tempted by trying to act like a GPO where you simply consolidate the volume and then you charge your members for that volume, basically replicating what the GPOs we used to do. Our suggestion here is this is a great opportunity for you guys to create what we call as a virtual private network, wherein a coalition would go beyond just providing contract management and volume consolidation services, but they would actually provide a technology platform to its members. They would provide real-time visibility into their spend pattern, cost savings recommendations. They would provide ease of executing these transactions, and end of the day, bring measurable results, all delivered on the cloud. That's what we would recommend to our clients who are looking to be that latter, which is going beyond mere cost savings, going beyond mere helping their own facilities, but to create a new generation revenue generation model.
All this is great. Can you also talk about the weaknesses or the failure points in this journey?
Destin, listen, any journey worth taking is not going to be easy. A sure way to be successful is to really plan for any kind of a contingencies, emergencies that could arise, look into the future, and actually anticipate what could go wrong. And in this situation, it helps to be like what Andy Grove used to say, hey, only the paranoid survive. It helps to be paranoid. So we would suggest to our clients to be paranoid about what can go wrong. Look at every contingency, look at every issue that you have, and imagine what if something like this could go wrong, what kind of a ripple effect it would have on your entire mechanism, and then be able to iterate on that business model as often as possible till you get to the optimum solution. The biggest weakness that we see in implementing very complicated models is a lack of the technology backbone with a lot of large health systems. Today, there is an reliance on the ERP systems, their legacy systems, so on and so forth. But if they have to go out and create a new business model, then they should be open to accepting third-party technologies and be able to implement them, integrate them so that they can provide a holistic business model that could even be used by smaller hospitals that really don't have the bandwidth, the maturity, and the investment dollars to do something big. So this kind of a model can bring everybody up to an optimized level where it's like a rising tide lifts everybody. So that sort of a situation would lift all of these rural hospitals, small hospitals, subacute care facilities and clinics, above the level that they are, and ultimately benefit everybody.
Oh, well, thank you, Ashok, for sharing today on this topic.
Thank you, Dustin. It's always a pleasure to talk to you.